Welcome back. In part 1, we built the complete framework, the foundation, the technique, Rinne, Weber, Schwabach, absolute bone conduction test, the dead ear trap, the full matrix. Now we find out if you actually understood it or just watched it. 3 patients are going to walk into my OPD today. Each one has a completely different story. Each one gives me a completely different set of tuning fork findings. And one of them, the third one, is going to make the textbook matrix look like it is lying to your face. I want you to think alongside me in real time, not memorize, think. Because that is the difference between a doctor who passes an exam and a doctor who actually helps a patient. So let us begin. Now, this is the patient number 1, a 42 years old school teacher. She walks into my OPD. She teaches class 8 mathematics, which already tells you she has the patience of a saint and the vocal projection of a foghorn. Her complaint: left ear feels heavy and blocked. This started 3 days back. Her own voice echoes strangely inside her head, a sensation called autophony. No pain, no discharge, no dizziness. But here is the detail that immediately gets my attention. She recently recovered from a mild upper respiratory tract infection. I pick up my 512 tuning fork, Weber first, midline forehead. She immediately says, I hear that buzzing much louder in my left ear. My internal monologue? Well, sound lateralizing to the symptomatic left ear. We have 2 possibilities. Left conductive blockage making bone vibration sound louder, or perhaps right sensory neural problem making the left ear win by default. Now, the recent URTI history is already nudging me towards conductive loss. So let us confirm it with Rinne. So we do a right Rinne's test, fork in right mastoid, or should I say fork on the right mastoid. Finger goes up, swing the fork to ear canal. She says, yes, I can hear it clearly in the ear. So right Rinne positive, right ear completely normal. Now the problem is isolated to the left. So we do a left Rinne test. So fork on left mastoid, 12 seconds, finger up. I swing immediately to the ear canal and she says, nothing. I can hear nothing. Which means she's got a left Rinne negative. Bone beats air on the left side. So the matrix delivers the verdict instantly. Left Weber lateralization, left Rinne negative, left-sided conductive hearing loss confirmed. I set the tuning fork down, reach for the otoscope again. And what I had seen earlier, which was a dull retracted tympanic membrane, a yellowish fluid line behind it, and air bubbles trapped in the middle ear, is confirmed by my tuning fork tests as my diagnosis, which is otitis media with effusion, left-sided. So what happened was her eustachian tube blocked during the viral infection and the middle ear filled with fluid. The nerve, the cochlea, is completely healthy and untouched. The conductive pathway is blocked. The sensory neural pathway is perfect. So the management would be watchful waiting for 6 to 8 weeks, decongestants. If it persists, referral for Eustache and tube assessment and possible Grome insertion. Patient 1, done and dusted. Clean, satisfying. Now let's move to the patient number 2. Now here walks in a 58-year-old retired factory worker, 30 years operating heavy industrial machinery. Now he presented to me with 6 months of progressively worsening hearing on the right side and a high-pitched ringing in his right ear, tinnitus, that he describes as sounding like a pressure cooker that never ever switches off. No ear infections, no trauma, no medications known to damage hearing. Just 3 decades of noise without adequate ear protection. I note the asymmetry immediately. Right-sided hearing loss, right-sided tinnitus, asymmetric presentation in a noise-exposed patient. My clinical antenna goes up. Weber first, midline, he tells me the sound shifts completely and decisively to his left ear. My internal monologue, sound lateralizing away from the symptomatic right ear. 2 possibilities. Left conductive blockage, unlikely given his history and no ear symptoms on the left. So it's highly unlikely. Or right sensory neural damage, highly likely given 30 years of industrial noise. So now let us check the Rinne's test. Left Rinne, positive. Left ear, normal. Right Rinne, I place the fork on his right mastoid. He signals when bone conduction ends. I swing to the ear canal. He says, yes, I can hear it in the air, but it is very faint and it fades out very quickly. Right Rinne, technically positive. Air is still beating the bone. Weber lateralizes to the left. Both Rinne's positive. The matrix says right-sided sensory neural hearing loss, confirmed entirely by his history as otoscopic examination had shown absolute clean, beautiful tympanic membranes without a scratch. So the middle ear mechanics are completely intact. The damage is deeper inside the cochlea itself. The hair cells destroyed by decades of noise. But I do not stop there, and this is the part that matters the most. Asymmetric sensory neural hearing loss with unilateral tinnitus is a red flag combination. I cannot simply fit this man in a category which says it's a noise-induced hearing loss and send him home. Why? Because a certain entity known as vestibular schwannoma, an acoustic neuroma, a benign tumor growing on the vestibulocochlear nerve, can present with exactly this profile. Asymmetric sensory neural loss, unilateral tinnitus, gradual onset, and if I miss it, that tumor would keep growing. So the management protocol would be a formal pure tone audiometry to quantify the deficit properly and precisely, of course, and an urgent MRI of the internal auditory canal to safely and definitively rule out any structural compression of the nerve. Safety before anything else, always. Patient 2, done, but with a critical safety net that the tuning fork alone could never have provided. Only clinical thinking could have provided that. Now let's come to the curveball, patient number 3. And I want you to stay very alert right now, because this patient is going to make the tuning fork matrix look like it is lying directly to your face. And if you are not thinking, if you are only memorizing, she will send you completely in the wrong direction. So here is a 35-year-old woman, 6 months of progressive, painless hearing loss in the right ear. She notices it most when trying to use her mobile phone on that side. No ear infections, no trauma, no noise exposure, no recent cold, no medications. And then the detail that a sharp clinician notices immediately, yes, immediately, and files away like a red flag in the corner of their mind crops up. Her mother developed severe hearing loss in her late 30s and required surgery. So, family history of hearing loss requiring surgery in the 4th decade of life, I note it. I say nothing yet. I let the tuning folks speak first. Otoscopic examination, both ear canals perfectly clear. Both tympanic membranes absolutely fine, translucent, healthy, mobile, not a single abnormality. So I pick up the tuning fork. Weber, placed on the midline of forehead. She immediately tells me, I hear that sound much louder in my right ear. So my initial thought is sound lateralizing to the symptomatic right ear. Standard thinking, either right conductive blockage or left sensory neural problem. But clean otoscopic examination makes a conductive blockage seem very unlikely. Let me check Rinne to clarify. So right Rinne test, fork on the right mastoid, she signals, I swing to the ear canal, she says, yes, I can still hear it humming in the air. It is quiet, but definitely there. Right Rinne test, positive. Air is beating the bone again. I pause, I repeat it to make absolutely sure the result is the same. Left Rinne, again positive, normal. And now, if you have only memorized the matrix, your brain hits a wall. Weber lateralizes to the right. Both Rinne's positive. The memorized rule says left-sided sensory neural hearing loss. But that makes absolutely zero clinical sense. This woman walked into my clinic complaining about her right ear. Her left ear is perfectly fine by history. So, how can the diagnosis point to the left? A student who memorizes would order a brain MRI looking for left sided nerve damage. Send an entirely healthy left sided nerve for unnecessary investigation and completely miss what is actually happening. So, what is happening? This is early otosclerosis, also known as otospongiosis, which in fact is the correct scientific terminology. So, otosclerosis is a condition where abnormal bone remodeling gradually fixes the stapes footplate in place. The stapes, the smallest bone in the human body, sits against the oval window and is supposed to transmit vibrations into the fluid of the inner ear. And when it gets fixed, it cannot vibrate, and sound transmission begins to fail. Now, here is the anatomy that explains the paradox. Why is the right Rinne still positive? Because in early otosclerosis, the stapes is only partially fixed. The conductive deficit is mild, perhaps 15 to 20 decibels of airborne gap. And air conduction is naturally so much more efficient than bone conduction by approximately 30 decibels. So it still wins the sprint. The blockage is simply not severe enough yet to flip the Rinne negative. So the Rinne says air beats bone, positive, apparently normal. And then why did Weber lateralize decisively to the right, the bad ear? Because Weber is a far more sensitive instrument than Rinne as far as a test is concerned. Even this mild conductive block, too small to show on Rinne, is more than enough to trigger what we call the occlusion effect. The partially fixed stapes acts like an acoustic mirror inside the right middle ear. It traps bone conducted vibrations inside the right cochlea and simultaneously blocks out ambient room noise from entering. The right cochlea is now sitting in relative silence, amplified bone conduction, no competing air noise. It hears the Weber fork with exaggerated clarity. So Weber detects this subtle edge immediately and shifts decisively to the right. The diagnostic conclusion: mild early conductive hearing loss in the right side, not left sensory neural hearing loss. The matrix misled you. Yes, it misled you. The clinical picture corrected it. And that family history: mother with hearing loss in her late 30s, requiring surgery, that was the otosclerosis diagnosis sitting in plain sight from the very first sentence she spoke. The tuning fork simply confirmed what the story already told us. Stepidotomy, surgical correction of otosclerosis, is exactly the operation her mother would have had. Now, the management: pure tone audiometry with something called tympanometry, specifically looking for Carhart's notch, a characteristic dip in bone conduction at 2000 Hz. That is the audiological fingerprint of otosclerosis, and an absent stapedial reflex. She will eventually be offered for the for the interim a hearing aid for just symptomatic relief, or a surgical stepidotomy for definitive correction. Patient 3, the curveball, caught because we were thinking, not memorizing. 3 patients, 3 completely different tuning fork profiles. 3 diagnoses: a school teacher with fluid in her middle ear after a cold which she had recently, a factory worker with noise damaged nerves and a red flag that needed an MRI, and a young woman whose tuning fork results defied the textbook until you understood the acoustics behind them. So, to summarize, the matrix is a tool, it's a starting point. It is not a substitute for thinking. The moment you stop thinking and start only matching some patterns, medicine will find a patient like patient number 3 and humble you completely, respectfully, but completely. If these videos helped you think differently about tuning fork tests, I have one request. Share them with one colleague preparing for FMGE or NEET PG or any other competitions. Not 10 people, just one. That one share might save them those marks, that lost time, and that damaged confidence we talked about right at the very beginning of part one. The complete Glorious Ruins clinical decision flowchart for tuning fork tests, covering all three tests, the matrix, the false negative Rinne trap, and the otosclerosis curveball, is available via the link in the description. Printable, exam ready, high yield. And if you want to go deeper across ENT, surgery, ophthalmology, pharmacology, physiology, and every high yield subject for FMG, NEET, PG, and other competitive examinations, the full Glorious Ruins course is waiting for you somewhere. Link would be active soon. I am Ashish, and this is the Glorious Ruins. I will see you in the next one.